So wireframe fracture considerations. So GORE devices, we know that they fracture. We knew this with the Helix. Beginning in the Helix trial, this was recognized. There were a couple papers of device-related trauma associated with the Helix device between 1999 and 2016. 30,000 devices were sold worldwide. We knew that this device fractured, but fortunately the clinical sequelae was pretty rare. This graduated to the 5-wire GORE CARDIOFORM ASD Occluder GSO device, first in human in 2011, 100,000 devices sold worldwide. Definitely had in the trial, in the GSO trial, I believe, and I might get the numbers wrong, but it was somewhere around 9% of the devices on fluoroscopy had wireframe fractures in them in the GSO trial. So they knew from the Helix experience that, and so they baked into that GSO trial, we're going to do fluoros to look for these wireframe fractures. When the Assured trial came along, which Athar just described to you, it was the same pattern. We're going to implant this device, and follow-up's going to involve fluoroscopic follow-up of the device. Since the GCA has been approved, there's been about 15,000 devices sold worldwide. And you saw in the trial, Athar kind of went through it, but half of those patients or more in the trial, when they had their fluoroscopy sometime within the first 3 years, had evidence of wireframe fracture. So we'll talk about that. So we knew going into the trial that GORE devices fractured from the previous trial experience with Helix and GSO. So everybody had required fluoroscopic evaluation in the Assured trial, and the intent was to try to define what the fracture rate was with the GCA and to see if it was related to any trauma. And Athar skipped over this, but in the trial at 6 months, there were 120, 96% patients had technical success. 104 of those patients had fluoroscopy, and when we looked at the data, 37% or 30, whatever that number is, a lot, okay? 36% had wireframe fracture. Now, at that time in the trial, we were thinking, well, maybe we're going to see any 10 to 15%, maybe 20%, based on the fact that we're putting these devices a little bigger, just using the GSO trial as the comparison. So when we saw 36%, that was concerning. And I will tell you, as being a part of the trial organization, we had a lot of conversations about this because when you looked by echo, none of this was evident, and there wasn't any clinical sequelae. So we were seeing patients come in, over a third of them were having wireframe fracture, which is more than we would have predicted. We knew there was going to be some, but it was more, but we weren't seeing clinical sequelae. So what do you do? I mean, what do? You're running a trial, and so far you don't know that it's not going to be a problem. This was GORE taking a deep dive into this to try to understand it better. So, which is a big deal if you're ever involved running a device trial. The budgets are massive. So to add a fluoroscopy that you weren't planning to do unto all these patients and trying to target all of them was expensive. But the reason for that is we really wanted to understand this problem to see if it was predictive of any sort of clinical significance down the line. This is what it looks like. On the left there and in the middle frame there, you can see that's a device that has that's probably a 44, I would guess, maybe 37 device. If you look, it's not going to show well, but trust me, if you look in the middle of that device, you'll see discontinuity in some of the wireframes, but it's only evident because you're looking for it on the echo, right? So if we weren't in a trial, we wouldn't have seen this. Here's another example of the same, looking at the echo from various views. No encroachment on any valves, no AV valve regurgitation, nothing, no effusions. Here's another example, again, looking at the echo showing this. So again, but the device is fracturing. What does this mean? And so it puts in your mind, like, what is actually happening? And hopefully we can talk a little bit about the dynamic nature of the atrial septum when I'm done bloviating here. But what we did was we looked at the 3-year wireframe fracture in 526 patients that had the technical success. And what we found was that if you looked at them at 6 months, like I said, 31% had wireframe fracture evident. And if you looked at them at 36 months, of the ones that came in, And we do think it's 185 patients who had their fluoroscopy. But look at that, 57% of the patients that had fluoroscopy, who had their fluoroscopic evaluation, had wireframe fractures. So it was even higher. Looking at it another way, if you look at all patients that had fluoroscopy at any time, that either the 6 months and 3 years, or just 6 months, or just the 3 years, you'll see that that breaks down to 42% of them had evidence of wireframe fracture. So just another way to look at that data. What about by device size? Well, again, if you look at the wireframe fracture in the overall in the 6 months and at 3 years, you can see 31% again at 6 months and 57% at 3 years. If you look at all the devices, the question is it just the big devices, is it the small devices? Turns out we see wireframe fractures on fluoroscopy in all of these devices. But importantly, what we have not seen is clinical sequelae in this trial population that I am aware of. So that I think is the bottom line. But it's not going to stop us from kind of obsessing about it. And again, this is another, it's kind of like, why do you keep looking? Why do you keep looking? Well, because I have to say, I was kind of a bit of a driver of this. Athar was a driver of this. Bob Summer, if he was here, because we want to understand what this is. Why are the wire fracturing? Is this going to be a problem for us? So one of the things we did was we worked with the GORE engineers and said, look, give us a heat map. Let's look at all the fluoros that we have and tell us where the fractures are. Because if the majority of fractures are in the middle of the device, remote from the periphery and not making contact with the myocardium, then maybe it's not something that we should be concerned about. So if you start in the middle of the device and you follow the wire around on its winding course, zone 1 is in the middle, zone 2 is beginning to turn, zone 3 is the periphery, and zone 4 is actually the anatomically adaptable waist of the wire. And when you look at this, you see that zone 1, 2, and 4 represent 93% of the fractures seen on fluoroscopy, which again I think is good news, because the wire frame, if it's fracturing, if there are loose ends of the wires, they're sort of centrally located and not in the periphery. Furthermore, if you look at the peripheral fractures, and again, one of the conversations we had when we decided to really take a deep dive into this was, all right, peripheral fractures, if maybe we should talk about if there's a peripheral fracture that we're seeing, those patients should have a different type of follow-up. And then the question became, well, if it's a peripheral fracture but the wire is facing inward and it's not poking outward, is that a problem? So we looked at that. And at any point, if you looked at the device as a circle on FOSS, we didn't see in the trial patient population any wires sort of pointing out beyond the periphery of the device. So that, again, we're seeing a lot of wire fracture on fluoro, no evidence of it by echo or clinically. And just looking at it again, over and over again, what are the risks? Are there patient risks? Can we blame the patients for this somehow? And what you find is that bigger patients, bigger defects with bigger devices were more likely to have wireframe fractures. If you quote unquote oversize the device, meaning for the 5 GCA devices that are out there, they each have a recommended size range for the ASD you should be treating. And if you pushed beyond that, so you put a big device into an oversized based on recommendations, well, then that was considered oversized. And all those ended up on a multivariate analysis being significant. So bigger patients, bigger defects, bigger devices, and oversized devices, it may just speak to a dynamic, more strain on those devices. Looking at it another way, if you look in the first 6 months, the wireframe fracture per patient was 0.6, and the wireframe from between 6 and 36 months was lower. It was 0.18, meaning that is that initial fracture a stress alleviating event, which then makes it less likely to have subsequent fractures? The answer to that is maybe. So again, it's another way to look at the data. But most importantly, is this a tempest in a teapot? And am I driving you crazy by over-explaining this? Maybe. Importantly, we have not seen in the trial population any evidence of a clinical problem. So what does all this mean? Well, what it means is that we're just going to continue to follow these patients by echo, where I've sort of abandoned getting routine fluoroscopy on these patients because it just ends up being too onerous for them. If there is something on echo and you see something new, then probably looking by fluoro or by CT scan would be helpful to see if there's any conformational changes in your device. And again, if you look at taking all this thing in aggregate, we know that these devices are subjected to ongoing compression forces, rotational forces, and other torsional forces that cause the metal to fatigue and to fracture. I have in our very large patient populations, we have not had device-related trauma to date that I know of, and there hasn't been in the trial patients who were followed very closely. And I'm curious to know those who are out there using it if they've had similar experiences. So with that, I'm going to stop.